Good morning. I'm the Kevin part of the Double Act, just in case you were wondering. I'm Director of Finance and Performance. And for colleagues in the audience who came to visit Derby yesterday, I hope you enjoyed the experience. Some of this may be a slight recap for you, but hopefully we'll also show you some other advances in terms of the way that we're actually moving forward. So just for the benefit of the whole, this is Derby Teaching Hospitals. We're a medium-sized DGH, £500 million turnover. We treat about 1 million patients a year in different settings. We have just shy of 1,200 beds, and we do all specialties apart from cardiac surgery and neurosciences. And when the hospital was built, when it was a new PFI, about 13, 14 years ago, they built 35 operating theatres within the actual hospital. And at the time, the surgical body thought that this was completely overkill. I'd just like to say, as you've seen from the rising demand on Philip's slides, I'm now full. I have to maximise the efficiency and the usage of those theatres, as it's rather expensive to actually build any more within a PFI. So what is now available at Derby? All our products are tracked to patients across all my theatres, including endoscopy and also including my cardio cath labs, as some of you will have seen yesterday. We have full traceability of trays, and Keith will talk about that further later on in the presentation. And more importantly, and this is the fact that I keep talking to the department about, we need to get this discussion in the NHS out of the supply chain. This system provides the basic management information that the NHS needs to run its business. And I say that not as an NHS person born and bred. I'm historically from the fluffy world of venture capital and from manufacturing. So we have a very different approach to in Derby to the way we actually operate our hospital. It is on commercial means, and we strive to improve our efficiency at every possibility. So you'll see, in particular, the emphasis on consultant-to-consultant discussions, and again, Keith will talk to you in detail about the conversations he has. And the ultimate aim will be that we move to case cart situations and product standardisation over the next 12 months. And as you can see, we are currently saving at least £1 million a year on consumable usage. And that's not price deductions from our suppliers, that's actually the more efficient use and the reduction in wastage within the NHS. And in particular, our coding improvement that has earned us over £1 million a year extra in terms of the income from our commissioners. But more importantly, and we'll talk about Big Steve later on, it actually has improved our hospital standard mortality rate, i.e. the rate in which the clinical efficiency of my organisation is actually judged by its peers. So you can see we've been on this journey now for just over 3 years. Actually been an early adopter by the department, actually helped to speed up the process. And at the time, we now have over 97,000 theatre episodes have been recorded. So we have a major database of information that we can use to identify patient outcomes and differences in clinical treatment. So we've applied GS1 standards on the patient wristband, so we can identify and capture the right patient. The GTIN for the products, the place, every location, including the stairwells within Derby, is actually coded. And we process GS1 standards throughout the whole of the business. This is our theatre capture device, which we use for scanning both in theatres and in our endoscopy suite. We scan the patient, We time the start of the procedure from anaesthetic all the way through the procedure and into recovery, and then out of recovery to the ward. We actually scan the location, who is present, and what actual job that they're actually doing. If there are any occurrences in theatre, the type of anaesthetic used, and then literally everything that touches the patient, and in particular, anything that's implanted within a patient. And again, you'll see from Keith's talk the benefit of that at a later time. This is our infamous Big Steve. This is actually copyrighted before you all start taking photos. This is actually developed using our own GS1 barcode license. And what we do is we record our comorbidities. And for the non-clinical people within the audience, those are long-term conditions that the clinician needs to know, as it will change or affect the level of treatment that he may be giving to a patient during a procedure. For instance, diabetes, whether they've got liver disease, if they've got a renal problem or an ophthalmology problem. Certainly in endoscopy, this has been a major improvement in being able to track our patient outcomes. So we now have positive ID on the patient. In addition to the traditional question of asking the patient their name, we scan the barcode. The system is expecting that particular person to be arriving at the anaesthetic room, and therefore we positively confirm in addition to asking the patient their name. And this now happens on wards, and this is now our new data capture system that is rolled out on wards, where we understand, or we undertake the same procedures that we do with in theatre, where we track the patient, what the procedure is, who's actually undertaking it, and with what devices. And that looks at developing training, development, and patient pathway. And as a result, my clinician can now, electronically at the touch of a button, track the patient pathway from the point of entering the hospital for an elective procedure, following the course of the treatment, and each one of those flags, there's the backup detail about who did what to who, with what, and when, so that the clinician can actually identify where something may have actually gone wrong in the patient pathway prior to the unfortunate patient having to go in for an emergency procedure a couple of months later.
So at this point, I'm going to take over the presentation as the clinician. And the important thing for me as the clinician is the patient. It's critically important that I know what's going on with my patient, and it's the patient safety issues and the performance issues as clinical director of surgery that matter to me, because I look after around 68 consultant surgeons within the hospital. So let me give you an example. If, for example, we have a product recall, because we have the system working as we do at Derby, once we're given the specific number of that product, we can then start to look and see who's been affected. So we can see from this that this is the patient number, the reference number, this is the product itself, and we know that this particular tray, for example, of instruments has been prepared by this particular company. So we can track everything within the system. And that allows us then to drill down to each individual procedure. So there's the patient number, this is the case study, and not only can we look at the instruments that were used on that particular patient, but we can see which members of staff were in the operating room. We can track each individual component of that complex procedure. And it means that we've got full product traceability, so we can look and see exactly who has had a particular product used on them. But you'll also notice, if you look at the bottom line numbers, that we've got a live costing as we go through our tracking and tracing procedure. So we know exactly what's happening with each particular procedure, and we have a costing and income figure for each thing that we do within the trust. And let me give you an example of how things have changed. If you think back to the silicon PIP implant issue, or something like that, then we manually tracked through and traced things. And this, if you look at the top line, this was our former method of doing it. So for example, this example is one of CJD. Then we would have to review case notes, we would have to manually identify trays and look out for those identified patients. But since we started tracking, we've reduced the time that it takes from 50 hours to 30 minutes to find those patients. And in this particular instance, we review now our HTRAC data, we can identify the trays very quickly, and we can identify the patients very quickly. And you can imagine that if you've got an infected situation like this, or a potential infection, the speed with which you're able to do this makes a huge difference. And the tracking and tracing with GS1 standards is what allows us to do this, and it's revolutionized what we do within the system. And not only one patient, we can look through and we can see exactly which instrument tray has been used on which particular patient. So we can identify very quickly those patients, and we can get to the core of the problem very quickly. So here's another example. You just imagine a situation where a patient has complex facial injuries and is treated in one part of the country. And so they have this complex reconstruction with titanium plates and screws, all that are of an individual nature in that particular hospital. We in our hospital don't necessarily use this type of equipment. However, because we track and trace, any patient that leaves our organization, we can tell them what screws are in, who manufactured the screws, what the product codes are, when they were put in, what type of screw head to expect, because often when you put in devices like this, you have to take them out at a later date, and we are able, therefore, to plan our procedures. We never go into surgery blind anymore because we know what type of screw head to expect, we know what equipment to use, and we know what we need to prepare in advance, all because we can track and trace what we use. And the potential for the NHS is amazing, because if patients don't stay in one location at one hospital all their lives, so whether this is a pacemaker, a cardiac valve replacement, it doesn't matter. If we can give the patient that information, or if that information is available from the hospital, then it's going to make a huge difference. And this is something that we've come across just recently, and it was just something that happened on a Tuesday evening. I was told that we'd had a problem with a patient who'd had a device fitted in Derby on the Monday. That patient had been admitted to a hospital in the north of England, and the device had to be removed quickly on the evening. And also, I learned that there had been a device failure intraoperatively at Derby with the same patient, so our alarm bells were going off. And then we found another patient had come to our trust from another hospital with the same device in, with a similar problem. And there was a third patient with a similar problem. Immediately, because of our tracking and tracing, we were able to identify the product that we had in stock and in the hospital, and we were able to take those out of circulation. And we're currently working with other agencies to investigate this particular problem. Now, the other thing I need as the clinical director is to look at the performance data of the surgeons that I work with. And if you look at this image, this is the variation in costs of consumables for six or for a group of consultants doing laparoscopic cholecystectomy. And what I'd like you to look at is look at the average length of time that this consultant took, and look at the average length of time that this one took. Look at the cost of the consumables here and the cost of the consumables there. Now, I'm not saying that speed is the essence, because what I want is good outcomes for my patients. But what this allows me to do is to bring a group of consultant surgeons together to understand why this one uses £285 worth of consumables, and this one uses over 30% less. And these are very valuable discussions within an organization as big as the organization that Lord Hunt has demonstrated to you. And equally, if you look at this chart, you'll see that if you look at this number of products used by this consultant and the number of minutes that this consultant took, and if you look at the number of products here and the number of minutes there, you think, well, this guy is quicker. Is he? If you look at the detail, and the devil is always in the detail, you'll see that we had 2 more members of staff in the operating theatre with the second consultant. So, as a performance manager, the data allows me then to say, well, hang on, we need to put 2 more healthcare assistants into this guy's theatre, and we can get another 2 cases through on every list. So this is affecting not just patient safety, but performance. So hopefully that will give you just a brief overview of what we've used our tracking and tracing information for at Derby. It has changed the way we do things, and it's now embedded in the activity within our organization, and we are sincerely hoping that we're going to get government support to roll this out across the UK. Thank you very much indeed for your attention.